Good morning, good evening, dear colleagues, ladies and gentlemen. This meeting is about to start. My name is Frédéric Aubrin. I am chairman of this session focused on postoperative pain management and acupuncture. And I share this session with Professor Gilles LEBUFFE from the University of Lille and Professor Dominique Fletcher from the University of Paris. And it's my pleasure to introduce the first speaker. And the title of your lecture is Evolution of Postoperative Pain Management in France and in the USA during the last 15 years. Please.
Thank you very much, Frédéric. So, dear colleagues, it's a real pleasure for me to share my experience regarding evolution of postoperative pain management in France and in US during the last 15 years. So the learning objective of this presentation will be to identify risk of severe postoperative pain and chronic postoperative pain. Also identify a validated tool to assess pain characteristic. Define multimodal analgesic approach and identify systemic analgesic class allowing a multimodal approach. So postoperative pain is defined by an unpleasant sensory and emotional experience due to tissue injury. And we know that 40 million patients undergo surgical procedure in Europe per year. Among these patients, 30% of them experience severe postoperative pain during the first 24 hours. And this is defined by a visual analgesic scale greater than 6. Also, 13% of these surgical patients experience a moderate to severe postoperative pain at day 3, but also 9% at day 14 after the surgical procedure. The origin of the pain is inflammatory and neurogenic, and this is associated with a peripheral and central sensitization phenomena. So we are lucky because we have now guidelines, French but also American guidelines, and these guidelines agree about something. The first of all is the preoperative pain evaluation. It's very important to evaluate this preoperative pain. And the American panel recommend a preoperative evaluation, including assessment of medical and psychiatric comorbidities, concomitant medication, history of chronic pain, substance abuse, and previous postoperative treatment regimen, in order to guide the perioperative pain management. French guidelines recommend to identify patients at high risk of severe postoperative pain and chronic postoperative pain. Most particularly, presence of preoperative pain at the operative site or not, the use of preoperative opioids. Surgical factors are also very important to identify, and also psychological comorbidities as depressive and anxiety. Katman in 2003 proposed a score included different risks which are associated with severe postoperative pain. And we know that female population, younger people, patients with high intensity pain before intervention, the type of surgery, the level of anxiety, the need for information, and the incision size are associated with a higher risk of severe postoperative pain. Regarding this risk factor, we know that younger population, preoperative pain, anxiety, and type of surgery are associated with a higher risk of high-intensity postoperative pain. Younger population, type of surgery, and psychological distress, as observed with catastrophic patients, are more associated with analgesic consumption. What is interesting also to observe is that these risk factors are also associated with a higher risk of chronic postoperative pain. And so younger population, female, preoperative pain, psychological and social factors, needs of the information, and type of surgery are also associated with this risk of chronic postoperative pain. This is interesting because these factors are associated with higher intensity after the higher intensity of pain after the surgical procedure, and this is a link between the higher intensity of postoperative pain and the emergency of chronic postoperative pain. Concerning the surgical risk factor, we know that the importance of tissue injury, the duration of surgery, the experience of the surgeon, and the presence or not of nerve injuries are associated with a risk of severe postoperative pain and chronic postoperative pain. In this table, you can observe that some surgery are associated with a higher risk of chronic pain. Amputation, thoracotomy, mastectomy. You can see that this intervention can be associated with an incidence of 30 to 80%, 60% of chronic pain. And so we have to be careful with this type of surgery about the intensity of postoperative pain and the risk of chronic postoperative pain. So we have to identify the pain intensity and the preoperative pain intensity, but also the post-operative pain intensity. For that, we use a validated pain assessment tool. And so you know the numeric rating scale, the visual analog scale. And so these scales are used in our practice in order to identify pain intensity. But French guidelines insist about the characteristic of the pain. And we are convinced now that it's very important to identify neuropathic component of this pain. And we can use a score. This is a very simple score with 4 questions. The 2 first questions is to characterize the type of pain as burning, painful cold, electric shocks, tingling, pins and needles, numbness, itching. This is very characteristic component of the neuropathic component. The 2 last questions, this is a clinical examination in order to identify the presence of hypoesthesia, to touch, to prick, and eventually allodynia symptomatology with brushing. And so if the score is greater than 4, the presence of component of neuropathic component is high, with a sensitivity and a specificity greater than 85%. So it's a very simple score to use in order to identify neuropathic component of the pain. Other guidelines, recommendation given by American guidelines, this is the necessity of a multimodal analgesia. And so the American panel recommend to offer multimodal analgesia to our patient. And what is a multimodal analgesia? This is the fact to associate different medication class in order to control postoperative analgesia. And the aims of this multimodal analgesia is to obtain an additive or synergistic effect by combining several analgesics with different mechanisms of action, achieve a superior postoperative analgesic effect, but without increasing the adverse effects. And if the patient requires opioid, so we have to associate a non-opioid analgesic class in order to decrease the consumption of opioid. This is what this slide proposes. So in context of a multimodal analgesia with acetaminophen, non-steroidal anti-inflammatory drugs, or selective cyclooxygenase 2 inhibitors, you can observe a significant decrease of morphine consumption. And so it's very important to associate this non-opioid analgesic class in order to significantly decrease the morphine consumption. But not only to the reduction of opioid consumption. The interest of multimodal analgesia is also to decrease adverse effect. As you can see here, we can decrease the nausea and vomiting, sedation, respiratory depression, urinary retention, pruritus, bowel dysfunction, dizziness. So it's very important to decrease adverse effect of opioid, because these adverse effects are associated with a late recovery of our patients. So we have to be careful with that. So what about now the systematic pharmacological therapies? Again, French and American guidelines agree about different points. The panel recommends oral over intravenous administration of opioid. So if your patient requires opioid, you have to prefer oral route. It is possible. In case of it's not possible, you have to prefer intravenous patient control analgesia. Why? Because when you use PCA, you can observe in this table that the pain intensity is lower, 8 to 8 lower than patient with non-patient control opioid analgesia. And so it's during the 24 hours after the procedural surgical, but you can observe also this is the same later. So we have to associated other non-opioid class, and if you use intravenous administration, you have to prefer PCA. Excuse me, we can, yes. So we have now the possibility to get non-invasive PCA. Non-invasive PCA allow the patient to get a higher recovery. In this slide, you can observe that the score of immobility is better when you use a non-invasive PCA system. This non-invasive PCA system, this is a transdermic PCA system or tablet, sulfentanyl tablet that the patient can use by PCE. And so when we use this system, you can observe that the mobility score is better in this patient, whatever age of the patient, sex, body mass index, or the surgery type. So it's important because we have to control pain, postoperative pain, but also we have to think to the recovery of our patient. Other concerning systemic pharmacological therapies, this is the non-opioid class with acetaminophen and or non-steroidal anti-inflammatory drug as a part of multimodal analgesia. And this is important that the French guideline give us some information to use non-steroidal anti-inflammatory drugs. Particularly, this agent is not recommended for a duration greater than 7 days in patients with an history of atherothrombotic disease. And it also not recommended in patients treated with anticoagulants. So we have to be careful with this agent. It's a good analgesic, but we have to use it in specific condition and not in patients with a cardiovascular history. Other drugs like that we can use for the multimodal approach, intravenous ketamine. Intravenous ketamine, this is a sharing point of view with American guidelines and also with French guidelines. You can see that the French guideline propose two situations for using ketamine administration. This is most particularly for patients for surgical procedure at high risk of severe postoperative pain and chronic postoperative pain, and also for patients at risk of severe postoperative pain, in particular patients with preoperative pain and more particularly if they use opioids or patient with an opioid addiction. And so ketamine is very useful for this population. Why? Because this meta-analysis shows us that ketamine reduces the opioid consumption, whatever the route administration, intramuscular, intravenous or continuous intravenous. You can observe in this meta-analysis a significant decrease of morphine consumption. So it's very important in certain conditions to use this agent. Another agent is intravenous lidocaine. It's a sharing point of view also between American guidelines and French guidelines. The French guidelines propose the way to use intravenous lidocaine with a bolus dose at 1 to 2 mg per kilo and then a continuous infusion at 1 to 2 mg per kilo per hour in patients undergoing certain surgery. And the publication, the literature show us that this is abdominopelvic surgery and also spine surgery when we get very good result with intravenous lidocaine. But we don't have to associate intravenous lidocaine with neuraxial therapies or peripheral regional anesthesia. We have to choose it's intravenous or it's a local analgesia strategy. And when we use intravenous lidocaine, we observe a significant reduction of postoperative pain, and we improve also, and this is very important, postoperative recovery. So in conclusion, I think it's very important that we have to identify patients at high risk of severe postoperative pain and chronic postoperative pain. And we know now that some risks are sharing between the intensity of postoperative pain and the chronic postoperative pain. So we have to assess the pain characteristic, its intensity, and the neuropathic component by using a very simple scale. And so we have also to implement a multimodal approach. What is this multimodal approach? If patients require opioid, we have to administer opioid, but we have also to combine non-opioid class agent in order to reduce opioid consumption and adverse effect of opioid. And so we have to think also to associate systematically, if it's possible, neuraxial therapies or peripheral regional anesthesia. And if it's very important to control postoperative pain, we have to keep in mind that we have to improve also the recovery of our patient. So this is the end of my presentation. And in this multimodal approach, what is the place of nefopam? And it will be Frédéric answer this question.
Thank you. Thank you very much, Professor LeBuffe, for this excellent presentation. And the session is open to questions. Please send us some questions about this lecture. I have a question about the level of risk. Do you assess in your department of anesthesiology and pain unit the level? Do you assess the level of risk of severe postoperative pain?
Yes, we have modified our practice regarding this aspect. It's very important. We are particularly careful with patients with preoperative pain at the site of the surgical procedure, but not only, also in the other side. And so with this patient, we identify in our file and we select this patient in order to modify our practice during the surgical procedure. We take and we perform such strategy regarding sparing effect of opioid by using ketamine and lidocaine, because in my department this is general surgery, and so in this context we use lidocaine, ketamine, but also corticoid and dexamethasone in this typology of surgery. But now in our practice, this patient has totally identified, and we are very careful to prevent opioid-induced hyperalgesia, and so our strategy now is to decrease the consumption of opioid in this typology of patient.
Thank you very much. And last question, short question, about pain management in the elderly population.
Yeah, in this population, we try to avoid opioids. And so, first of all, we think about local and peripheral analgesia, if we can. And so, this is the first objective. After, we avoid some agent, as tramadol. We avoid this agent because we have a higher risk of delirium with this in elderly patient. And so when we take in charge elderly patient, so our main objective decrease opioid. We perform analgesia, local analgesia strategy, and we avoid tramadol. So we use Acetaminophen, we use Nefopam, and from time to time, if we don't have any contraindication, kidney failure, we use non-steroidal anti-inflammatory.
Okay, thank you very much, Professor LeBuffe.